Good morning, everybody. Thank you for joining us today. Thank you, Mika. Hi, good morning, all. I'm Dr. Kate Leritana, and I'd like to welcome you to our second session of the HIV Complex Medical Management Quality Improvement Learning Session. So happy to be joining you all on this cloudy/rainy Thursday morning, and thank you for taking the time to join us today. We have a lot in store for you, and I'm so excited to begin today's meeting. Next slide, please, Mika. By the way, I am joined by our partners from PSMID, SHIP, and UCSF. For today's house rules, please mute your microphone and turn your video off if you have low bandwidth. But if your internet's good, you can leave your videos on. Please ensure a stable internet connection. Participants are encouraged to rename themselves as first name and last name, hyphen, affiliation, or facility. You may type your questions in the chat box. Later on, we will be sending an attendance form through the chat box. We would kindly request everybody to kindly fill it out. For today's agenda, we have a full session. First, we'll have a recap of our first session. It might be a while since 2 months ago, so I will be happy to recall the highlights for everybody. Next, we will have a QI mentoring summary and a lecture on identifying the problem and root cause from our quality improvement specialist, Sir Ilde, whom you must have met by now. This will be followed by a presentation by one of our participants, Dr. Jonah Adun, a ID fellow in training and a medical officer of the Research Institute for Tropical Medicine. This will be followed by our paper case, which will then lead us to our didactic topic for the day. This will be facilitated by our expert lecturers, Dr. John Jamowski and Dr. Emma Bainbridge from UCSF. And then we'll have the very exciting question and answer portion before we end today's session. This will be led by Dr. Janice Kawili. All right, let's begin. Let's dive into things. I will be sharing with you a recap of the case discussed during our first session. Next, please. The highlight then was management of a complex medical case which had HIV drug resistance. This was followed by a lecture done by Dr. Emma Bainbridge, which had the following summary of our case. So we had a case whose genotype had the following mutations. There was an intermediate or high-level resistance to each component of the first-line regimen at the time, which was tenofovir, lamivudine, and efavirenz. The patient was switched to a second-line regimen, which was lamivudine, zidovudine, and lopinavir and ritonavir. We also discussed, next please, some basics of HIV drug resistance, and the following take-home points were given. A viral load of greater than or equal to 1,000 copies should prompt HIV resistance testing and the switch to second-line ART. The second-line regimen should contain at least 2 or preferably 3 active agents. The mutation M184IV confers high-level lamivudine M-tricytabine resistance, low-level abacavir resistance, and an enhanced susceptibility to zidovudine and tenofovir, and reduced viral fitness. The mutation K65R confers high-level tenofovir or TAF resistance, intermediate abacavir, lamivudine, and emtricitabine resistance, and enhanced zidovudine susceptibility. The mutation K103N confers high-level resistance to both efavirenz and nevirapine, and is the most common transmitted mutation. And we were introduced to the Stanford HIV database, which is an interactive tool that can be used to analyze a patient's genotype. So coming off from this, we had a major issue which was discussed during our question and answer portion. And this was the current variation available for our genotype results, which is currently provided by two major institutions in the country. It's the National Institutes for Health, located in UP Manila, and the Research Institute for Tropical Medicine. And since one of the objectives of our quality improvement learning network is to decrease variation in HIV medicine practice, we thought that it would be best to sit down and have a conversation with these two facilities and ask for their help in achieving our objective. Next, please. And that's what happened. We actually met virtually with the MBL staff of our ITM, led by Mr. Timothy John Dizon, and we also corresponded with the head of the NIH Molecular Biology Lab, who was Dr. Edsel Salvania. And we agreed to work together to be able to have standardization of our genotyping results to better help our clinicians, which are you guys, in making clinical decisions in the future. So let me share with you what came out of that conversation. So unfortunately, Dr. Edsel Salvania is unavailable to join us today, but I did send Sir Edsel a few questions, which was common among clinicians regarding genotyping. And hopefully, these questions that I gave to Dr. Edsel also reflected your concerns. Next, please. So my first question was, in the NIH result, as you can see here on the left, it says for research use only. Why is this, and what are the implications for clinician use? So Sir Edsel responded, 2 reasons. First is that NIH is a research laboratory, and our DOH license is as a special research laboratory. The second reason is that our HIV resistance test is based off of the WHO protocol, and it doesn't use a specific commercial kit. HIV genotyping is a highly specialized testing process, and the protocol itself can be performed multiple ways. The sequencing process is also not standardized and is machine dependent. And this is also true even for commercial kits, since they are dependent on sequencing platforms for the final sequencing. Even the Stanford database used for interpretation is constantly changing and is not standardized. Therefore, the data that is generated needs to be interpreted by a clinician in the context of an experimental test, which is constantly evolving. That is an ongoing research effort. Next, please. My second question, do you recommend that we still refer to the Stanford database, or is NIH doing that for us? Hence, the interpretation part. We use the Stanford database and algorithms to generate the scoring and the interpretation. Anything that Stanford flags as low-level resistance should be interpreted as resistant by clinicians. But since not everyone knows this, the NIH recommendation reflects the recommended treatments based on this interpretation. Next, please. Provincial samples take time to be sent if ever they are. What solutions do you have in mind for this problem? What is the maximum turnaround time for for NIH for a sample coming from the region furthest south of the Philippines, which is Mindanao? And would you recommend waiting for the result before switching? We can turn around a sample in 2 weeks. If it takes 2 weeks for a sample to get to us, then the longest would be 1 month. I would still wait for the result before switching. Long-term solutions are setting up testing laboratories in different provinces, but that would also mean capillary sequencing facilities. We are planning a clinical trial using Minion as a sequencing platform with a validated PCR that only needs one reaction. We will be presenting this in ID Week, and we are in the process of applying for a grant for the clinical trials. Next, please. And this is my last question. Does the DOH need to send a memo for result standardization? I don't think so. The basic problem is that this is an evolving test and is considered experimental. I think that it is enough that the labs who are doing the testing listen to the stakeholders, depending on what information they want and what is most useful for them. I think the process you are doing is the best way to move forward. And last slide, we asked for a message of support from the NIH regarding genotyping standardization. I think that coming up with a consistent process for reporting resistance plus adding clinical recommendations will help our doctors take better care of people living with HIV and strongly benefit our patients in the long run. NIH fully supports this process, and we are happy to participate in future meetings. All right, so that is the message from NIH's very own Dr. Edsel Salvania. Next, please. Since we also are in discussion with the Research Institute for Tropical Medicine, we have two special guests with us today who can provide their insights on the process of our standardization. We would like to invite the Chief Science Research Specialist and Medical Officer 4 of the Research Institute for Tropical Medicine, Dr. Timothy John Dizon, to give us a few words regarding the current process that we have started a few weeks ago. Hi, Sir Tim. Welcome.
Okay. Good morning, Doc Kate. I'm glad to join you here in this talk. So we have met a few weeks before to discuss the standardization of our HIV-DRG results, and our team here at RITM MBL is looking into improving our results form, and looking into providing recommendations similar to what is presented in the UPNIH results. So we're also looking into improving our HIV DRG assay. And currently, our teams are like what Dr. Salvania has said in his message, looking into using Oxford Nanopore Technologies platform to improve the HIV-DRG assay that we have. Currently, we are using Sanger-based capillary-based sequencing for the genotyping results, and we're hoping that the shift to a different sequencing platform would make the process easier and more cost effective, and of course to have a better turnaround time for our results.
Thank you so much, Sir Tim, and we appreciate you joining us this early, although I did to have this portion at the latter part of the session. So thank you for accommodating our
No
changing schedule.
worries, Doc. Doc Kate.
Salamat. Salamat po. So we'd like to thank our ITM for joining us today. Please feel free to join us for the rest of the session. Thank you. All right. I also had sorry, Mika, we can resume our slide sharing, please. I had the pleasure of speaking with Dr. Telan of San Lazaro Hospital. And although it is still unofficial, she shared with me that San Lazaro may also start providing this technology for us, although it is still located in the NCR and specifically Metro Manila region where everybody else is. We're hoping that another laboratory to help us out in our genotyping would serve the rest of the country. So we really have to talk about the logistics part so that our service will be available to everyone in the Philippines, no matter where they are. So it's something to look forward to. All right. Thank you. Thank you for the whole team of our ITM NIH for having this conversation with us.